Good morning, everyone. Could I just take opportunity on behalf of the College of Physicians here in London to welcome you. The weather is not too good at the moment, but I am assured by the Met Office that we will see some sunshine later today. You are very welcome here at this conference venue. It's more than a conference venue, it's the elegant buildings of a membership body with over 30,000 members and fellows working across all aspects of healthcare to do with physicianly practice. And can I just add my thanks to Christopher's thanks to both Susan and Mark. It's been great to work with them in planning this inaugural event, and I very much hope that the networking, the critical thought, the sharing, the innovation, the ideas, the excitement is brought together in a very keen way over the next 2 days. You have a great opportunity at looking at sort of the international audience that is coming together, thought leaders and innovators. So I very much welcome the opportunity to share with you some of the policy context around the future hospital. The building here is just over 50 years old. We celebrated its 50th anniversary last year. Sir Dennis Lasdun's Grade 1 listed building is the envy of many architects, and we're particularly proud of the building here. So there's a lot of synergy, I guess, with you hosting this first event here at such a great building. The college itself is nearly 500 years old. It was established by a royal garter by King Henry VIII. We celebrate our 500th anniversary in 2018, and it's interesting that the royal charter at that stage is as relevant today as it was then. It was established to really address variation in practice, and that was the practice of some rogue clinicians masquerading in London, as well as maybe the more professional aspects of the medical profession at that time. But to address variation in practice was right at the heart of the Royal Charter. We are still addressing really the heart of that message in modern healthcare. We are aware, with such high-profile media reporting around variation in practice, that one of the basic requirements of perhaps a level of sophistication in an advanced society is access to healthcare at the right time when the patient needs it. And the College of Physicians is very committed to that principle. If I can just show you some of the images of the building that we used for the 50th anniversary last year, I'm sure that you will begin to appreciate some of the elegance in the designs and the finishing and the sophistication of Sir Dennis Lasdun's projection, I guess, into Regency England here in the heart of northwest London. We're particularly proud of the buildings, as I've said, and I hope that you can explore the building and its history whilst you're here over the next couple of days. If we come back to the real focus to this plenary session, right at the heart of what we're trying to do as a leading professional body in the healthcare landscape is to really live this vision of the best possible health and healthcare for everyone. Our mission is fairly straightforward: influencing the way that healthcare is delivered and designed, and that includes the physical environment as well as patient flow and patient management. Promoting good health and leading the prevention of ill health across communities, and supporting physicians to fulfill their potential as leaders of the interdisciplinary team. The RCP sets higher standards, and the work we do here is right at the heart of improving the experience of care and also outcomes of patient care. Again, the resonance there around the physical environment and the way that care is organised across traditional care sectors such as tertiary or secondary, in the acute sector, primary going into the community setting, and more latterly, the dependence on social care and how funding tends to be often constrained in silos across that trajectory has been problematic for patients of increasing age and increasing complexity, and I'll come back to that in a little while. We're committed to these values, their principles, I guess, that drive the whole programme of the college. The college is around a 40 million business. I'm responsible for around 120 staff that really just focus very carefully on improving care for patients, and that is around a third of the staff and a third of the income that goes as a significant professional commitment to really reach into some of the complexities around healthcare in the 21st century. Our 5 strategic aims are pretty clear. They're to improve care for patients, develop physicians through their careers, through our work in education and training, to lead and support our members wherever they may be. Around 20% of our membership is international, 80% is based in the 4 countries of the UK, the majority in England and Wales. We'll shape the future of health and healthcare by lobbying and really being at the heart of thinking in terms of thought leadership and influence to policy and to government. And we'll invest in our future and build on our heritage that you will hopefully get a sense and a taste of over the next 2 days. So over the next 5 years, we have said when we launched our 5-year strategic ambition at the beginning of this year, we will support physicians and multidisciplinary teams to lead quality and service improvement. Both of those aspects are dependent on the locality and the context of care, including the physical environment. And so to work in partnership in reaching into that ambition is something very close to our heart with an audience like yourselves. We are committed to set, measure and promote standards that improve care for patients, and perhaps more importantly, the experience of care for patients. No longer are we target-driven from a policy context in the UK, but we tend to lend ourselves more to an outcome-orientated ambition, and experience is right at the heart of that, not just patient experience, but I'm sure David will touch on this in his presentation, the whole well-being of the staff that give that care within the context of care, and the importance of staff well-being in producing quality of both experience and outcome. We will implement our vision for the future hospital that promotes good practice in health service design. I'll be speaking in more detail on that, and to develop health services that promote these 3 aspects, I guess, that have been identified as either direct or proxies of high quality, and that is patient safety, both the experience of care and also how staff engage in that process of caregiving. And it's in this latter aspect of the future hospital that we're now going to spend the majority of the rest of this presentation. The Future Hospital Commission was established to deal with the increasing complexities that we see within an ageing population. No longer do we have a focus on single organ disease, but we're seeing people live to a trajectory of age that means that they have a complexity of multiple problems that they're experiencing. We describe this as multimorbidity, and the relationship between those single morbidities can also increase complexity. We know also that the majority of our population in hospitals, particularly in acute care settings, are aged. And so the Future Hospital Commission was a real commitment to work with high-level stakeholders to really reach into the problems that we were experiencing at the end of the single figures of the 21st century going into 2010 and beyond, and the Commission reported in 2013. And the Commission at that time of report really resonated with so many people across healthcare sector, healthcare policy and healthcare thinking. That led to a high-level editorial in The Lancet, which described the Commission's report as perhaps the most single important piece of policy thinking to happen in the last decade. We then published our next generation journal, the Future Hospital Journal, and that's an invitation to you, and I will revisit that at the end of this presentation, to consider some of the groundbreaking work that you're doing into this field to actually publish that. I know that your own Blair Sadler has taken that opportunity with colleagues in the 3rd edition of the Future Hospital Journal, and that is designed to really bring together a high quality of international thinking around improvement methodologies and improvement science. We then launched from concept really into practice and practical design 4 development sites where we're starting to test some of the principles that I will share with you and how they link to some of the national programs and our conversations with government on how we support those national programs. So the Future Hospital really is around the principles of how we redesign healthcare traditionally to where it needs to go for the 21st century. Some of the media around the launch of the Commission report you can see here. This is just a sample of the media. And so I guess we have established ourselves with a fairly hefty task of continuing not just to be in thought leadership, but also in practical delivery of some of the aspirations that we share here to really improve the lot of the patient in the 21st century. Partnership working is key to this. Working in isolation, I think people have long realised that there remains a paucity, and so the strategic links and trying to join the dots up across other significant organisations, professional bodies, policymakers is crucial, because the problem is bigger than any single provider. And some of our key stakeholders are represented on this slide. So the vision for the Future Hospital is attracting a fair bit of attention. And I guess we've moved from really the bell ringing in 2013 and 14 into an articulation of the sophistication on how we take new models of care and how we create the conditions for innovation to happen at a very practical level. All of the leading political parties committed to really embed the thinking of the Future Hospital into their pre-election media and into their pre-election commitments, and we have a healthy relationship with this majority government as we do with the other political parties in the UK. But perhaps the majority government gives an opportunity that didn't exist in a shared government for the Conservative Party to really drive through some of these issues right at the heart of this thinking over the next 5 years. The link to some national programs I will allude to. So when I talk about Vanguard and Pioneer sites, they're also similar concepts that have emerged out of the group that really determines health policy and delivery in England and Wales. We refer to those as NHS England. So why is there a need for a new vision of clinical care? Well, in the College of Physicians, we're used to working from what the evidence says. To be opinion leaders is okay, but it's important to really be driven by hard data. And what does that hard data say to us? Well, there is rising clinical need. There are changing needs at a population level. We know that there is a fragmentation of care in the way that care is delivered across healthcare settings in the UK. We also know that recently there's been a breakdown of care provision out of normal hours of care delivery, and they would nominally between 8 p.m. at night and 8 a.m. in the morning. And we also know that through some policy implementation, like, for example, the European Working Time Directive and its impact on the medical workforce, but more importantly, the attraction of people into healthcare, that there is also a medical workforce crisis for us to be at the heart of, and that's why training and education is so important, as well as some of the other aspects to this new vision. Nearly 2/3 of inpatients in the UK are over 65. Half of those over 60 have a chronic illness. And of that half, a quarter of those have dementia. And it becomes a very difficult challenge to care for that type of person in traditional healthcare environments. We know, for example, that hospital episodes of delirium happen frequently where there is a disorientation, particularly in the early hours of the morning, for patients who are elderly. And we also know what the data says, that one experience of a hospital delirium will increase their risk of dementia, and dementia becomes an increasingly burdensome condition, not just for the individual and the carer and family, but it is a highly costly condition to really manage effectively at a population level. And we also know that within the complexity, there are increasing numbers of patients who have multiple conditions, and this is part of the reason why we've seen a fracturing of care. The College of Physicians put its hand up at this stage to say, well, we may be partly responsible for this historically. Within the speciality of physicianly care, we have 29 subspecialities, ranging from people who look after skin to your heart and everything in between. And it's that reliance on specialism that sees when a patient has 3 or 4 different things wrong with them, you can see that there is a lack of coordination across the specialists who are delivering that care, and also an increasing burden at a societal level in terms of cost. And so the future hospital needs to reach into that complexity. If we look at the drivers of change for hospital services in Europe and NHS, we know right across Europe the same situation exists when we talk to our European partners. Changing in both age, comorbidity and the expectations of care, mainly through smartphone technology and the access to information highways, and the fact that most people in a modern society can get an answer very quickly via smartphone technology. In terms of quality and safety, we're seeing some of the evidence around fractured care, the multiple bed and team moves that happen, which have a negative impact, I guess, on both outcome and experience of care. We've seen an increase in mortality from some of the data, how reliable that data is, but it causes us concern to see that increase in mortality in out of hours and particularly over the weekend. And in this country, we had a very hard lesson to learn in the area around Mid-Staffordshire, in the centre of this country, where we saw really suboptimal care delivered over a period of time of 2 to 3 years that really was not just embarrassing for anybody involved in healthcare, but there were really sad stories related to that, where patients were dying unnecessarily. And we refer to that as the Francis Inquiry. Undoubtedly, you will have seen some of that. The European Summit for the Future of Hospital Service in 2014 was reported by the Nuffield Trust as really needing to see some creative thinking on how we embrace this present series, I guess, of problems that are presenting, and how we are part of the solution in terms of professional bodies, professional organisations, thought-leading organisations like the King's Fund and the Nuffield Trust in this country, and the Health Foundation, in partnership with politicians. Within that context, there is a constrained resource. We can see that clinical demand is increasing, admissions are increasing, the workforce is struggling, and so we have a description of a healthcare service that we're incredibly proud of and delivers year on year improvements in service, but is stretched at the seams. And so perhaps now is the time to really give some thought around how we reach into that with new innovative solutions. So what does the Future Hospital report cover? It has 5 work streams, and within that 23 case studies, so lots of data that really drives organisation of medical care and teams, the way that we need to reach in with new models of roles for the medical workforce through our education, training and deployment of medical staff activity, building a culture of compassion and respect in healthcare, management, economics and leadership, and looking at some of the solutions perhaps outside of healthcare and bringing those in as is consistent with improvement science and the importance of information systems. The principles, therefore, get translated from the Commission into the Future Hospital recommendations. And these are the principles. I'm not going to go through them today. It's a busy slide. If you want to see any of these reports, they're freely available on the RCP external-facing website, and I'd be happy to provide hyperlinks to all of them. In terms of new models of care, this is perhaps where the thought leadership from this college is really reaching in, and how that is beginning to disseminate across whole healthcare economies within this country. Within the medical division, we particularly in the top left-hand corner wanted to focus on the coordination of care. So new roles like the Chief of Medicine and the Chief Registrar roles are being embedded into plans around workforce appointments to really think about how we coordinate these patients who have the most complex care needs to get access and exposure to the right specialist care at the right time in an efficient way. And so some of the Future Hospital is beginning to see how we're redesigning patient flows, and the physical environment supporting patient flows becomes incredibly important at that stage. If we think about the recent Commission on Improving Urgent Care for Older People, which is, I think, a shared responsibility and a shared burden right across Europe, we can see that there are 4 main areas of thinking differentiated by the colour. Interestingly, in the bottom left-hand corner is the importance and the emphasis on the physical setting and the physical environment, and the importance that has to play in support of innovation and healthcare improvement thinking at a healthcare professional level. So it's a partnership commitment. It will be a partnership solution. People sitting in this audience will have a large part to play on how we reach into the provision for patients who can expect high quality care at the right time in the right place. Innovation shaped around patient flow and need has also been illustrated by the first emergency care hospital that has been built in this country that was recently opened last week, June the 16th, up in Northumbria Healthcare. The conditions for that are good in the sense that there is a stable leadership within that health economy. Jim, the CEO there, has had a very stable leadership team, which is a combination of both managers and clinicians taking the senior leadership clinical decision-making responsibility. And this new Northumbria Hospital provides the hub for emergency care, which brings specialists into the same place for all patients to be seen and coordinated over the first 48 to 72 hours, with 3 further larger hospitals really aggregated across what is a fairly rural part of England in the northeast, and then 5 community hospitals that can be also further outlying posts that become an opportunity for transfer of care into a lower level of skill need. And we're watching this with both interest and also with caution, I guess. At a health policy level, the de novo Manc commitments really are also interesting to us, where a whole health population in Manchester, the second largest city in the UK, has seen a devolvement in decision making to that region. And that's the reality, I guess, and also the opportunities that devolution brings, that governments give to regions of countries, whereby they're able to really control the costs associated with care delivery across all settings, regionally and locally. And that, again, is another innovation that we're watching with great interest. So, the policy context in the UK is very clear. We've moved from a target-driven mentality to an outcome-driven mentality. And people's experience of care becomes increasingly important, placing the patient right at the heart of decisions about themselves and about their care trajectory is also right at the heart of that thinking. Don Berwick in 2013, at the invitation of this government, said we needed to place the quality of patient care, especially patient safety, above all other aims. We needed to engage, we needed to empower and hear patients and carers at all times, fostering wholeheartedly the growth and development of all staff, including their ability and support to improve the processes in which they work. We needed to embrace transparency, unequivocally and everywhere, in the service of accountability, trust and the growth of knowledge. And let's not forget that this really came at a time where trust was being questioned, perhaps at a national scale in the NHS, for the first time for many years, following the Mid Staffordshire inquiry led by Sir Robert Francis. So we know that quality improvement is right at the heart of the solutions for future healthcare. These are the recommendations that Don Berwick gave to the government. I just want to really highlight those right at the heart of that. To the mastery of quality and patient safety sciences. And we know that the organisation of people within physical environments is right at the heart of the evidence that gives high outcomes in delivering that aim and ambition. That the NHS, the care sector, in support of the social sector, care sector, need to be learning organisations where we can work in partnership at looking at finding those solutions together. And transparency in the way that we use data to drive improvement is at the very heart of the way that progression or a progressive healthcare service delivery model will happen. So the Future Hospital programme has 7 focus themes. Patient-centred care, we're running projects around shared decision making, and we're testing patient experience also at a local level in our development sites. Quality and standards are right at the heart of the Future Hospital, using an eclectic quality improvement range of methodologies to illustrate that when we report it in the peer review literature. Information and data, consistent high quality information and data, is also right at the heart of the way that we can capture that experience across trajectories from primary into tertiary and vice versa, and also reaching into social care. Workforce remodelling, which is data-led and not opinion-led. Academic medicine and research is crucial if we're going to provide a legacy for our children in terms of this strategic thinking. And education and training right at the heart of the way that we're shaping the future workforce, and organisational development. I'll talk about that in a little while. So additional projects that are ongoing and current are shared decision making, the transition of young adults and adolescents through their care needs, a review of integrated care, which becomes increasingly important for the UK, integrated care across all boundaries of care, and the role of the chief resident. So from concept testing, the Future Hospital development sites are really designed to really look at working with local teams and to express the ambitions that we have in the programme and to animate those at a very local population level or health economy level. We're working in partnership with clinical teams, implementing projects aligned with the Future Hospital principles, local patient involvement, planners of care, and the RCP Carer Network are right at the heart, the beating heart of that work. Access to quality improvement expertise, policymakers and national stakeholders in partnership. We're evaluating and promoting those development sites, and this developing shared learning principle where we have coined a social media movement, if you like, called Tell Us Your Story, which is outside of the development sites, right across health economies in the 4 countries of the UK, and internationally for people to share their learning across a SharePoint platform where we can diffuse some of that learning, which is immediately accessible for those people planning care. So the secret of change is to focus all of your energy not on fighting the old, but on building the new. And so whilst the data is, I think, pretty overpowering, it's what we do with that data around where we are now to where we want to go in the future. And you guys are going to be part of that solution thinking. So taking the Future Hospital Commission from page to practice shows how we're currently taking the recommendations and translating those into very practical settings in 4 parts of England and Wales. What works and what doesn't work. We want to demonstrate service change is possible. We're seeing the enthusiasm, commitment and expert support reaching into that. We're identifying and promoting existing good practice and reviewing recommendations and priorities alongside the importance of sharing that learning and debate and championing the principles of the Future Hospital programme. So the development sites align with those principles. They place the patient right at the centre of the project in both planning, implementing and impacting service change. Patient experience is right at the core of evaluation, and it's as important an outcome as any that we will be looking at over the next 3 to 4 years. And the principle here that we have as a professional body leading in this space is collaborative partnership. So in terms of the outcome measures, you will see heterogeneous outcome measures traditionally aligned to the peer review literature. That may be door-to-doctor time, it may be mortality, morbidity, it may be hospital length of stay, frequency of specialist input, etc. And each of the development sites will have control over that themselves. But right at the core of the programme are 3 fundamental aspects that you need to measure. One is, what does the patient say? 2, how do the staff respond into that? And 3, what is the capacity at a leadership level to bring about sustainability in leadership in those healthcare economies? And it's those core metrics that we're starting to talk to national leaders in the Vanguard and Pioneer programs, potentially sharing those metrics so that we can really increase the power of the data that is driven through the evaluation of the Future Hospital. We will underpin that with health economic analysis and some modelling, because with innovation and improvement, you would expect to get some efficiency in the system, and we very much hope to be able to deliver that for the 4 development sites. Our development sites are shown on this slide. Just out of interest, you can find more about these on the website here. It was an open competitive tender process. We'll be going for a second tranche of call later this year and adding in another 4 development sites, and the likelihood is another 4 development sites towards the end of 2016. So we think with a pool of between 8 to 12 development sites, we will have a significant part to say in the future of healthcare shaping and delivery, both the physical and the care flow environments going into the 21st century. The problem in the UK is that you have a rash developing over the UK map a bit like this. And we think there is a little thing called initiative itis happening, whereby the thought leadership And the principles of the Future Hospital programme is actually impacting on many, many different initiatives. So we have the Vanguard sites, we have the Pioneer sites, we have some testbed sites. And what we're saying as a college here is that we must get data that is meaningful across all of these sites. And so the core metrics is something that becomes part of a broader conversation that we're having with government and with NHS England on how we deliver that piece. This is some of the detail around the programme evaluation. I think the slides are being made available on the website supporting this, so please take time to have a look at some of those metrics. The quality improvement implementation survey is a North American Berkeley University tool which is validated, that helps us look at both the culture and the context of leadership producing sustainable improvement. The NHS Patient Survey Staff Wellbeing tool is one that we modelled here and validated here, and we'll be using that to really capture data on how staff engage with the changes that are happening on the development site. And the patient experience metric is a continuation of the evidence work that we did in the National Clinical Guidelines Centre and the quality standard that was launched in this country, and has more latterly shaped and informed the National Quality Board's commitments to placing the patient at the heart of care. What's interesting is when you bring people together, you start to lose some of the professional competition that has happened in relative isolation, where you've got specialities delivering in that siloed mentality. So Worthing Hospital, I'm just going to show you a short video to articulate what they've been doing in redesigning the emergency floor, was brought together as a team, and the people driving that was a surgeon, an acute physician, a manager, a patient and a geriatrician. What a powerful combination of a collaborative team to really think through how we get people into the front door and manage them effectively across a whole range of conditions. And so their aims are pretty important, and their objectives and evaluation and strengths, I think, have got a large part to play in the way that we diffuse the learning on a site like Worthing, where we get repeatable or generalisable solutions for other parts of the UK. This is the emergency floor as is designed. Again, you can look at that in more detail when you get access to the slides. But the whole notion that you're bringing specialists together to actually receive a patient means that you can actually control the flow a lot more quickly. There are four main settings here through the front door of the emergency floor. There is acute medicine, acute surgery. There is a specific area for the elderly population, as well as ambulatory care. I have some emerging data just to show you at the end of this presentation. This is what it used to look like. This is what it looks like now. Let's hear a little bit more from Worthing from the video.
Future Hospital Commission sets out a vision for a new way of delivering care. The emergency floor at Worthing is a new development in which we've brought together acute medicine, acute frailty unit and acute surgical admissions into one footprint, so that we can provide joined up care for patients from the point at which they arrive all the way to the point where they go home. It's not a new concept, but it's an evolution of an idea that patients don't always present with a clear set of needs. And sometimes somebody's referred to medicine who actually needs some input from the surgeons, or vice versa. Somebody might present who is frail, elderly, who needs input from a multidisciplinary team, and what we aim to do is provide that here. The multidisciplinary team is there to address those needs on an individualised basis, and it really speeds up the process from the point of arrival all the way through to discharge. We've got access to physiotherapy, occupational therapy and social work teams. We've got a pharmacy team who are there to ensure that patients' medications are correctly prescribed, that if they need to go home on new medications, we can quickly get access to those medications and get them home with them. So each part of the team is working together to improve the journey for the patient all the way through the process. We've divided the area into 4 zones. Zone A is ambulatory care. Ambulatory care is an important part of acute medicine. It's a way for us to rapidly assess, provide a treatment plan and a discharge plan for patients who would have previously been admitted to hospital. Within ambulatory care, we've got different components. We've got an area in which we've got trolleys and chairs and we can see patients. We've got a waiting area and we've got a procedure room and a consulting room. And that allows us the flexibility to take people to whichever area they're most appropriately seen in and to move them around so we can get people seen quickly. We run the area with a nurse and a doctor working very closely together, and we've had great success already with surgical patients really coming in, being assessed rapidly and either going to theatre or going home if appropriate. So we've seen some really good positive early benefits already. Zones B and C are areas in which patients, either medical or surgical or elderly care patients, will spend up to 72 hours, and during that time they'll have intensive therapy, medical treatment and a plan already in place for their discharge. And then that moves us through to Zone D, which is the Department of Medicine for the Elderly, or the Acute Frailty Unit. So we're quite unique in that we have an independent acute frailty unit within the emergency floor, and that allows us to focus our attention, particularly with regards to the multidisciplinary team, on the needs of the acute frail patients.
So one of the great benefits of the emergency floor is we've co-located the acute frailty unit onto the emergency floor. So we've brought the geriatricians next door to the physicians and the surgeons, which means that we are all working as one big team, but the patients that need it get a comprehensive geriatric assessment at the point of entering the hospital. And so we lead a daily multidisciplinary team meeting where we look at not just the medical, but the psychological, the social implications of a patient's admission, and we decide where we can manage them appropriately and come up with a treatment regime for them. And then in bed 20, 91-year-old gentleman who lives in a 4-bedroom bungalow with his wife. He's independently mobile. He's been walking about a mile in the last year, and he sometimes uses a stick outside. He came in with a fall. Plan is to try and get him up and about. He does have a postural drop, so we might need to keep an eye on that. Physio-wise, what's he like?
Yeah, he did well. He got out of bed independently, walked 60 metres with frame.
Okay.
Quite steady.
Yeah.
Perhaps home tomorrow with Ray.
Okay.
The MDT meetings have been a great change in that having a twice daily meeting with the whole MDT can come together to discuss patients. We can quite quickly work out his needs medically and more holistically, so that we can then action those and hopefully get the patient home quicker and safer with the whole team working together.
It's built around each patient's needs. It's about reducing the number of moves for patients. It's about getting people home safely, with everyone working together to deliver the highest possible care for our patients. And that's what we're doing here in Worthing.
So I'm conscious of time. Christopher's been very kind. I'm just a couple of minutes over. What we're beginning to see from the data that is emerging from Worthing are some really interesting trends on how we can manage the pressures within the system by actually changing the physical environment and the emphasis on patient flow and the way the teams work together. As I conclude, I've referred to the Future Hospital Journal. It is an opportunity for you guys to take seriously. We would love to see some of the thought, leadership and activity from this group really presented in that journal, similar to Blair Sadler's recent article. So there's an invitation to contribute to international learning. The details are there. And finally, get in touch with us if you want to share some of your stories around the Future Hospital, or you've got a story of innovation and improvement to tell. We would love to hear that, and I very much hope that helps establish the context and really raises the sense of expectation for the next 2 days on the importance of what the discussions and presentations happen here and how they relate to the reality in the way that we're delivering care in the 21st century.